For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up. Season 3, Episode 16 of Surfing the NASH Tsunami. Our discussion of how data modeling can inform drug development starts now.
This week on Surfing the NASH Tsunami.
We've built mathematical models for about 15 countries to look at the burden of NAFLD and NASH. The model starts in 1950 and it goes all the way through 2050, and we can actually project what the population of NAFLD is and NASH and advanced stage disease. And an important part of this is that we look at uncertainty around all these modeling outputs. And that's kind of the name of the game with NAFLD, is when we look at disease progression of NAFLD and NASH, and we know that patients can progress and they can regress.
You can see 3 to 5 years in the future when drugs come to market is what about F2? Because you've expanded the population dramatically. The time horizon to having a negative liver outcome and the probability of a negative liver outcome are certainly a lot lower than they are for cirrhosis or even F3, but you're kind of right in the middle of all these metabolic syndrome issues. Can you comment on the value of treating at F2?
I think you can make a compelling case for treating F2.
So what we currently lack is those estimates from this type of data, because I agree with, I was actually part of that meta-analysis, and I think most of the time frames were 1 year apart, and not a lot happens in 1 year. And between that and variability in biopsy reads, you cannot get good estimates. What you're saying, the focus should be in waiting more time to actually see what happens, and ideally maybe pair not just biopsy data, but with other non-invasive tests, and then correlating with clinical outcomes.
Chris, you said you did lots of countries. Which are the countries you're most concerned about going forward in the modelling? Who are the big risks?
Where you really see very large growth is in countries like China, because the obesity epidemic didn't begin until in the past couple decades. It's just been a skyrocketing rate of increase in childhood obesity in countries like China. And when you look at the future, the numbers are pretty scary.
I guess the answer is you need more clearer data that links these risk factors closer and stronger. We're seeing a lot of innovation in the field of NITs, as you've highlighted. We're in the need. Alina has done a lot of work on MR imaging and also ultrasound-based technologies, which are a little bit more available in Europe. We need to enter those into the big databases that you are using to then model the outcomes. That's very important.
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join hepatology researcher and key opinion leader, Professor Jörn Schattenberg, liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and this week's guests, hepatology researcher and key opinion leader Dr. Alina Allen, and Center for Disease Analysis Foundation epidemiologist and modeler, Chris Estes, as they discuss what we can learn from data modeling and epidemiology, this week on Surfing the NASH Tsunami.
Today's episode of Surfing the NASH Tsunami is sponsored by Resoundent, a Mayo Clinic company, and the developers of magnetic resonance elastography. MRE is widely available with over 2,000 locations worldwide and can be done as a low-cost, rapid exam in just 5 minutes. Together with PDFF, this quantitative exam is called an hepatogram, a powerful non-invasive alternative to liver biopsy in many cases. For more information, visit www.resoundant.com on the web.
Для всіх, хто цікавиться мережею NASH або загалом жировою хворобою печінки, ловіть хвилю.
Okay, so the first thing I want to do is I want to thank, again, our friend Anna Tokar for doing such a nice job of translating our opening line into Ukrainian so that I don't have to mangle pronunciation on a word-by-word basis. And as with previous weeks and future weeks, our thoughts and our hopes and our prayers are with the people of the Ukraine as they deal with this horrible situation in which they find themselves. Second, there are a couple of things that make this episode different. One of them is we have an extra episode coming at the end, as we already noted, sponsored by Resoundant. But what's interesting is that usually when we have an extra episode, it is a continuation of the discussion of the episode and the same cast of characters. This is a completely different topic and a completely different cast of characters. I will talk more about that when we get to the extra set. And the second thing is that makes this different is that we've kind of improvised this topic, and I'm really excited about it, but it's a little bit of risk every time that you do a topic that isn't about a paper or anything that anybody can cleanly define in advance, and that's where we are today. So please join us on this adventurous journey, or quasi-adventurous journey, because after all, we can edit the tape, and we will go forward. Today we have with us, as always, Louise. Hey, Louise, how are you today? Louise Campbell.
I'm very well, thank you very much. Nice to be here.
Okay, good. And Jörn Schattenberg. Jörn, how are you today?
Good evening, Roger. I'm fine. It's the calendaric start of spring today, and it gives me vibes and energy.
Yeah, it did, and it informed my 10K run on Saturday in a really nice way, actually. It made it enjoyable as compared to merely tolerable. Okay, and then also Alina Allen. Hey, Alina, how are you today?
I'm good, Roger, and everyone. Thank you for having me again. And I want to add that it's spring even here in Minnesota, which usually catches us around halfway through the winter, but not this year. So I share Jörn's excitement about good weather.
And further excitement for those who've been following us, we've been talking about the Barcelona event on May 6th and 7th that Jörn is co-chairing with Jeff Lazarus. Alina, it turns out, will be joining us in Barcelona as well. So she and I got to meet in person for the first time 2 weeks ago in Phoenix, and this will be the second time in 2 months. So that'll be good. And we will have a fantastic cast of characters there. We'll talk about that when we do the preview episode on April 4th. And then finally, Chris Estes is back, our friend from Chief Modeler and Epidemiologist from the Center for Disease Analysis Foundation. Chris, how are you today?
Hey, Roger. Glad to be here. We had a little bit of spring in Colorado, but we just got another snowstorm last night, so hopefully we'll get some warm weather soon.
Yeah, I was going to ask you about that. So with that, why don't we just kick right into our groundbreaker? One good thing, personal or professional, that's happened to each of us in the past week, and you can't simply talk about it being spring because we've already given that one up. Brave one, go first.
Just this past week, I like to mountain bike, so I was able to get out on my mountain bike. Finally, we had enough snow melt that I could get out there and do that this past week. That was probably the most exciting thing.
I was going to say, connecting to the spring theme, I had my parents-in-law over for the weekend. We had a barbecue, and I played around a little bit in the garden, trying to make my lawn look fresh and everything. So that was kind of a gardening weekend. It was a lot of fun.
Fantastic. My win for the weekend was both my teams are in the FA Cup semi-finals, and they've been drawn opposite each other. So I'm going for a Liverpool Crystal Palace final at for the FA Cup. So my husband on one side and me on the other. But, so that should be good. So that was a bit of excitement.
So when Liverpool plays Palace, what do the kids do?
Well, one's a Chelsea fan. One's not into football at all, and the other one's avid Palace. But they all enjoyed the event because there's nothing like a Palace crowd at Wembley, as Man United found out a few years ago.
Well, a personal accomplishment for this weekend was that I survived hosting a girls' slumber party for my daughter's 12th birthday. So I have a preteen, send vibes.
Yeah, I raised a couple of those as a joint custody single parent for 7 years. I learned more about little girls than I ever thought I was going to, and by and large, it was the best experience of my life. But there were those slumber parties when for the next 3 days you asked, why did I do that? Actually, the worst is I once threw a picnic for my daughter's birthday in a park with 35 9-year-old girls and had 3 friends to help us keep track of everybody for 2.5 hours.
Pretty brave.
You put GPS trackers on them, right?
No, I didn't, Jörn, but I didn't have to run that weekend. I did well more than it was more than your 13K soccer match kind of running during that event. All right, so I'll stay with Louise's theme. Tottenham's won 2 matches in a row for the first time in forever. It shouldn't please me so much, but if Liverpool does what they should do to Arsenal and we do what we should do to Arsenal, we may actually make the Champions League. It's Tottenham, so I can't even hope for that, but I can dream. I can dare to dream. Let's just leave it at that. Okay, so with that, let's dive into today's episode. This actually came from the last time Chris was on. As I listened to what Chris was talking about, it struck me that this podcast is never really focused on all the benefits that we can get out of learning from data modeling and epidemiologies and the ways that Chris does it. And since one primary focus of the podcast is drug development and another is better care of patients, all those issues seem to roll together. So what I'd like to ask Chris to do is just take maybe 3, 4, 5 minutes, sketch out a couple of thoughts you have. I know you had talked before, one thought having to do with drug development and another one having to do with patient treatment that go in somewhat different directions. Floor is yours.
Oh, thank you, Roger. Just some background is we've built mathematical models for about 15 countries to look at the burden of NAFLD and NASH. The model starts in 1950 and it goes all the way through 2050, and we can actually project what the population of NAFLD is and NASH and advanced stage disease. And an important part of this is that we look at uncertainty around all these modeling outputs. And that's kind of the name of the game with NAFLD, is that when we look at disease progression of NAFLD and NASH, it's often based on liver biopsy studies. And we know that patients can progress and they can regress. So they could go from F1 to F2, or they could go from F1 back to F0. And there's a huge array of uncertainty around these progression rates. And that's kind of our biggest challenge in modeling. modeling is understanding what portion of the patients with NAFLD are progressing in any given year, what portion are regressing, and how can we identify those patients. So liver biopsy, it's an invasive procedure, and it's a burden on the patient. We know from previous studies that just due to sampling variability in liver biopsy, you have, if someone is, for example, classified as F3 on the first biopsy, and they go back for a second biopsy, there's over a 30% chance they'd be classified as F0 or F1 on the second biopsy, just due to sampling variability. So when we model, we kind of actually look at the whole NAFLD population holistically, and we keep track of the country. We build these models for countries, so we have the country's whole population. We have background mortality, so we're keeping track of patients who die. And then we also take account of elevated mortality. So we know that people with NAFLD, especially NASH, are going to have excess background mortality due to cardiovascular disease, complications from diabetes, or these other facets of metabolic syndrome. So we keep track of all these things over time and look at how the patients progress. Now, how do we validate the model? We validate the outputs of modeling using end-stage disease. So we look at what data are available for liver cancer. And when we look at this, again, there's uncertainty. There's underreporting around liver cancer. So there's studies from Australia and Sweden that show that, up to 50% of liver cancers may not even be reported to central registries. And then there's uncertainty around how many liver cancer cases are classified as NASH. So we have a large number of cases that are classified as idiopathic or cryptogenic cirrhosis when they're really NAFLD or NASH related. So what we do in modeling is we end up with a range. What is the plausible range of liver cancer cases that could be attributable to NAFLD or NASH? And we validate the model results using that. Now, in terms of drug development, when we look at that, in order for a patient to receive a therapeutic, they have to go through several steps. The population at risk has to be screened, and the people with NAFLD and NASH have to be identified, and we need to identify those who are most likely to progress. And from there, there's a need for further diagnostics and linking people to care at that point. So in order for these therapeutic compounds to be effective in the future, there needs to be a program to screen patients, and we also need better non-invasive diagnostics other than liver biopsy, non-invasive, that will help us identify those patients most likely at risk for disease progression, and then diagnostics where the same patient can be tested over time and we can keep track of disease progression.
Chris, thanks for that. So let's stay with the part about diagnostics first. And the question becomes, when we say we need better diagnostics, exactly what do we need them to do in the community, and how much of this is about clinical care pathways, and how much of this is about, once you've identified a patient at risk, doing the right thing, or what is the right thing to do once you identify a patient at risk? What do you need to know from a modeler perspective?
We need to know the other characteristics of the patient. What is their age? What are the comorbidities? And, how are we going to find these patients? So when we look at the U.S. data, in the U.S., there's over about 37 million people with diabetes, but almost 1/4 of those, we have over 8 million people in the U.S. who are diabetic and don't even know they're diabetic. They're not even diagnosed. So, we know that NAFLD is more closely associated with obesity. So in our model, we actually use obesity as a marker for NAFLD. We assume that NAFLD is going to increase in tandem with obesity. But we look at diabetes as being more associated with NASH. So just looking at something like diabetes, there needs to be programs to screen people, not just for diabetes, but for liver disease as well. Those with the most severe forms of metabolic syndrome, we expect to be most at risk of disease progression, but we really need better tools to identify those patients.
If I may say something, Roger, and Chris, thank you for sharing this, and congratulations again on all the great modeling work you've been done. My concern is always that, of course, we have to rely on those proxies you use, as you've highlighted, diabetes and obesity, to say something about the liver. There's a certain disconnect, and as I also highlighted, not all are diagnosed. It's the same perspective on the liver end of the manifestation, because a lot of patients living with diabetes don't know they're cirrhotic. They have cirrhotic liver disease. So it's always difficult to use these proxies. And I guess the answer is you need more clearer data that links these risk factors closer and stronger. And I think we're seeing a lot of innovation in the field of NITs, as you've highlighted. We're in the need. Alina has done a lot of work on MR imaging and also ultrasound-based technologies, which are a little bit more available in Europe. We need to enter those into the big databases that you are using to then model the outcomes. That's very important. The other thing is, I'm always puzzled if I look at obesity rates. I'm not too certain they're well captured in all databases that I'm looking at either. So maybe a thought from your side there, how robust you're using obesity as a proxy, but how robust is obesity then coded? And that's for a start. But I have many thoughts on that, and I think we'll see better in the future because we're just gaining additional information on NITs.
Jörn brings up a good point about when we look at obesity, when we look at overweight too. In the U.S., we use cutoff values, a BMI, body mass index of 25 as a cutoff for overweight and 30 for obesity. These numbers were chosen arbitrarily. It's an even 5 cutoff. And we think that these numbers will vary between countries just to ethnic genetic differences. So a BMI of 25 in Japan may not mean the same thing as a BMI in, for example, a South Pacific country. When we have looked at cutoff levels, we've actually varied it by country. So in China and Japan, we'll actually use a lower BMI cutoff. And when we look at the data, especially from, say China and Japan, a much larger portion of the NAFLD population would be classified as lean NAFLD. So they're not overweight, they're not obese, but they have NAFLD. It becomes arbitrary when we try to create these classifications. So one of the reasons we did use obesity or the obesity and overweight is because the data have been collected so long. So Lancet has, in their global burden of disease, has estimates going back to 1975. Whereas if we look at diabetes, the challenge with diabetes is the portion that's diagnosed and undiagnosed changes over time, and that varies between different countries. So we do need better markers. And, a lot of the studies of disease progression have been very reliant on liver biopsy. But we know that the patients that undergo liver biopsy probably aren't representative of the entire NAFLD NASH population. Just, it's an invasive procedure. And, it just for a person to get to the point where they're having a liver biopsy probably means that they're not fully representative of the entire population.
Yeah, these are great points that highlight how much is a gap in what we know in NAFLD. And I think these will be important once we have a drug, once there's something on the market, how to identify these people, how we stratify them. But if we move back to the current realm of clinical trials and drug development, where we do have all these parameters, we don't necessarily have to make assumptions or have difficulty diagnosing obesity or stratifying by diabetes status. There we have, by all means, everything we need from non-invasive tests to clinical parameters to biopsies. Chris, where do you see that there's improvement, or how can we improve this arena with the kind of modeling that you do to improve maybe the very high placebo response rates, or maybe minimize the time that we have to wait for these clinical outcomes to occur or histologic outcomes that are currently used? Where do you see in this realm room for improvement with the modeling type that you do?
We have these meta-analyses that look at disease progression. And a lot of people have seen, I think it was the Singh 2015 article, that they did a meta-analysis of disease progression. But for certain stages, when they combined all the studies together, you actually had disease regression. And this was all just due to mostly due to sampling variability in liver biopsy. So it's these longitudinal studies where you go back to the same person again and again and again, and you perform the same measures and you see the changes over time. And you get more reliable longitudinal measures. A person at this age with this number of comorbidities what is their chances in the next 5 or 10 years of progressing from F1 to F2 or F3 or becoming cirrhotic? So it's really the long-term follow-up and really refining those longitudinal data.
So what we currently lack is those estimates from this type of data, because I agree I was actually part of that meta-analysis, and I think most of the time frames were 1 year apart, and not a lot happens in 1 year in between that and variability in biopsy reads. You cannot get good estimates. So I think the focus is what you're saying. The focus should be in waiting more time to actually see what happens, and ideally maybe pair not just biopsy data, but with other non-invasive tests, and then correlating with clinical outcomes.
Yeah. Also tying this into the other facets of metabolic syndrome is understanding what portion of the patients that are F3 are also, have serious cardiovascular disease and other comorbidities, and how that's going to, impact disease burden going forward. So when we look at the end stages of NAFLD and NASH, we see a large competing mortality effect where these other facets of metabolic syndrome are contributing a lot to excess mortality as well. And hopefully, a therapeutic compound wouldn't just reduce disease burden with NASH, but also help alleviate some of the other burdens of metabolic syndrome.
That leads me to kind of one of the things I've been wondering about, which is the debate you can see 3 to 5 years in the future when drugs come to market is what about F2? Because you've expanded the population dramatically. The time horizon to having a negative liver outcome and the probability of a negative liver outcome are certainly a lot lower than they are for cirrhosis or even F3. But you're kind of right in the middle of all these metabolic syndrome issues. Can you comment on the value of treating at F2 and based on the work you've done, the ability to understand which patients you're going to more likely want to treat at that point in therapy with drugs as compared to just as diet, lifestyle, whatever else?
I think you can make a compelling case for treating F2. So there's studies that look at liver cancer among NASH patients, and some of them find that 30 to 40% of liver cancer cases are occurring prior to cirrhosis. Now, as you go down, less fibrosis, there's a decrease in liver cancer, but we know that there's F2 patients that are developing liver cancer. It's a very expensive disease to treat, and in terms of cost effectiveness and mortality, life savings, improvement in quality of life, even these F2 patients should be screened at minimum and should be considered for intervention. And it doesn't just have to be a therapeutic compound. It can be lifestyle intervention as well, that we all know about weight loss and exercise.
An interesting point. Let me just follow up, Roger. We agree that there's non-cirrhotic NASH HCC, and it's driven by inflammation, but it's also driven by the amount of fibrosis. I'm not too sure about the F2 HCCs, Chris, and I think it's probably misstaged F3s or pre-cirrhotic then. While I do agree that there is a compelling argument that could be made for treatment in those, I think from what we know, it's more in the metabolic benefit, overall mortality benefit if we treat the liver than probably liver endpoints. I think that's tougher to show. And there's probably uncertainty, as you highlighted, around the stages, the correct staging in these patients. And 30 to 40% is nothing that I would see here, but there are clearly cases that fall in the non-cirrhotic categories.
Do you think that the drive to look at the F2s and below will be driven by the cost of the medication at a higher level? Because once we start to get the medications to market, it is going to be highly expensive. And that is a burden of cost that a lot of health authority or health providers are actually going to want to reduce. Whilst they're going to be doing it retrospectively, despite information prospectively that we know this is coming, they'll wait until the cost starts to mount up. Therefore, they drive their own cost to reduce it by looking at F2, looking at lifestyle, disease management, and screening earlier. So do you see it coming that way around rather than using the information that you and your teams and all of the data provide, that we know this is coming? It's not going to be a surprise. It's just going to be a very expensive wake-up call.
Yeah, when we look at obesity, for example, we see that the greatest acceleration, the obesity rate in the U.S. was accelerating the quickest in the 1990s. And that happened a little bit later in some other Western countries. So when we think about, NAFLD and NASH is a disease that can take decades to progress, we're just, at the beginning of sort of a tidal wave. So it was, only in the post-war period where, the rise of processed food and the sedentary lifestyle is when it really started. But it's been accelerating all the way through the 90s. And we do see a large population that's at risk of disease progression, and it's just going to get worse in the future. And the latest data we have from the U.S. show that the increases in obesity were accelerating in the 1990s, and then there was a leveling off where obesity was still growing in the U.S. There was a leveling off. The latest data from the pandemic show that stopped. Obesity is accelerating again, just as a result of the pandemic, especially among younger people. So we have the data now to show that. It's really also goes back to the diagnostics, is identifying those earlier stage patients who are most at risk of progression.
Let me walk that back to F2 for a minute, because when you talk about obesity, overweight, diabetes, cardiovascular, does the work that you do suggest that there are certain combinations of risk factors where in F2 they'll lend themselves more to drug therapy versus less? I ask in part because health systems are going to have to deal with it, but in part because one of the places where to me it bridges over to drug development is if I was developing a drug for F2 and I knew where the economics of risk and the epidemiology of risk were greatest, then that would tell me which patients I want to be focusing on in trial. I'm not sure trial works that way. I don't do trials. Jörn and Alina, you can comment on that better than I, but I'm curious, Chris, to what degree you see patterns that make sense at that stage in disease that would drive you in one direction or another in terms of recommendations to treat or how to treat.
Alina and Jörn, feel free to jump in. I think you're more familiar with the markers of F2. The assumption is that increasing severity of obesity and diabetes, we see greater level of obesity within an individual, and diabetes at an earlier age, it's more likely to progress versus someone who's, say, just overweight and late middle age. population is pre-diabetic and late middle age. So it's also has to do with the duration. When we look at childhood obesity, what is the impact of someone becoming obese when they're a child and living like that, being obese for decades and being pre-diabetic as a young adult versus someone who develops diabetes and obesity at a later age?
Yeah, my opinion is that this is very complex, and in terms of trying to make all the assumptions and model this is a lot of parameters to keep in mind. So as simple as age, if you consider that. So if you diagnose somebody who's 70, let's say, as an arbitrary age, who has stage 2 fibrosis versus somebody who's in the 30s, and then their competing risks are going to be different. I assume, without a lot of modeling, that the 70-year-old is going to probably die of cardiovascular disease or cancer, whereas the 30-year-old has a lot of decades ahead of them to develop liver-related disease. And then the second aspect is, what kind of drug are we talking? Are we talking an antifibrotic, which is unlikely to impact beneficially cardiovascular mortality, versus a metabolic drug who is likely to impact that? So there's so many strata of how you approach this in terms of modeling. And in my view, it almost sounds like this should be based on mechanism of action, the patient's comorbidities, the patient's age at diagnosis. So there's a lot of parameters that need to be kept in mind. Once we have drugs, depending on their mechanism of action, we almost will have to do something like a benefit or futility model approach, because the cost, as Louise brought up, is going to be very high. So is it going to be worth putting an antifibrotic into a 70-year-old with F2? Probably not, but maybe a different aspect to an anti-metabolic agent. So I don't know if you agree with this, Chris, but that's how I view this problem.
Yeah, I mean, you bring up a good point. So when we do our model, we account for excess cardiovascular and other non-liver related disease among the NASH population. And there's studies that also find elevated risks of non-liver cancer among NAFLD and NASH patients. But once they actually reach a cutoff, and different countries use different cutoff levels, but in the 70, 80-year range, we assume that there is no more excess non-liver mortality, with the assumption that people that are developing NAFLD at that late age are probably not going to be progressing, to advanced stages. And then as well, there's other factors. Gender, we think that males might progress faster, and then also comorbidities, as Alina mentioned, and then, possibly genetic factors that may not even be understood yet. So there's still a lot of research to be done.
Yeah, I fully agree with Chris and Alina, and it shows you the beauty on how physicians judge their patients. They walk through the door and you probably get a lot of visual input. The way they start talking, you get an idea about the education, potentially their time to think about food, and all the complexity of a patient that then is in front of a physician. The physician makes very simple calls and decisions and simplifies that, and the models are much complexer. Anyways, why am I saying that? I think there's a certain subcategory in F2s that is in the snapshot moment that we stage the patient F2, doesn't tell us anything about the dynamic of the disease. And age is an important factor, but there's certainly fast progressors. So the concept of fast progressors, and F2 patients progressing quickly would need to be treated. We're focusing on fibrosis and cirrhosis here from the liver endpoint. Are those with the patients with a lot of inflammation in the liver? Are those the patients with a high NIT that might predict that type of progression? ELF has been established as something leading to liver endpoints. So if I have an F1 with an ELF of, let's say, 11.6, is this a patient that's more progressive? Now, ELF is not the best example because it also correlates to the disease stage, but you get the idea. I mean, there's more than the liver stage to the patient than the stage when he walked through the door. There's many more aspects, and that's difficult for models because it's not linear again then, because if that patient changes something dramatically or gets bariatric surgery and drops 50 pounds, it just changes the natural history. And that's, I think, the main problem we're seeing here in predicting the future with that dynamic disease as it is.
Chris, you said you did lots of countries. Which are the countries you're most concerned about going forward in the modelling? Who are the big risks? And I know the pandemic may have thrown that out slightly, but I'm presuming, having seen an awful lot of patients recently, the pandemic hasn't treated them very well from their weight, their motivation. So it's probably going to, as you've already alluded to, escalate the problem. Who are the big countries that we need to watch out for in the world of the way this is going?
Well, we look at it in two ways. We have, the general background population of countries. So we can look at a country like Japan, and the prevalence rate of, NAFLD and NASH are increasing, but the whole country's population is actually decreasing at this time. So the number of NAFLD and NASH cases remain, almost constant, because it's just a country with an aging population that's declining. Where you really see very large growth is in countries like China, because the obesity epidemic didn't just start, didn't begin until, in the past couple decades. And, it's just been a skyrocketing rate of increase in childhood obesity in countries like China. And when you look at the future, the numbers are pretty scary because you have such a large group of people who until a few decades ago, they weren't. It's really the adoption of the Western diet, Western lifestyle, the sedentary lifestyle that's very rapidly increased the population at risk in China and other countries that have more recently developed. Now in Europe and North America, it's a growing burden, but it's more being driven by the aging. The baby boomers in the U.S. is a large cohort who's now experiencing the results of decades of increasing obesity and diabetes. So it depends on the country's underlying population, and then what did the trajectory of the obesity epidemic look like in that country. We're using obesity as kind of a marker for how NAFLD or how fatty liver disease is increasing. And then we also look at drinking. So we talk about non-alcoholic fatty liver disease, but unless there's no drinking at all, there's an arbitrary cutoff between what's alcoholic liver disease versus non-alcoholic. But usually there is some component of alcohol involved.
Yeah, and I think that's been important in a couple of the sessions that I've done recently with patients who don't realise when their BMI is high that alcohol intensifies. So that the units aren't recalculated depending on the BMI and the strength of alcohol and its effect on the body. Most of them, to be fair, aren't aware. So whilst they may be drinking in with the recommended limits, 14 units for a man and woman, actually with their BMI and their obesity, that can change drastically. And yet nobody's ever recalculated what they should be drinking to stay within recommendations for their size, realistically. So they think they're being good and they're not necessarily being as good as we think they're being. So it's the more awareness that patients get, I think the more we're learning, the more we need to be handing that information out.
We see this in some of the big elastography studies that have gone into the general populations of Europe, where they look at, what portion of the population has elevated liver stiffness. And you see even among young people, a fair portion that have elevated liver stiffness. And now they screen the population that, they do a questionnaire, and if you were above the cutoff, they're going to say that that's not NAFLD related, that's alcoholic liver disease. But what portion of those young people are somewhere between not drinking at all and in between that cutoff for alcoholic liver disease? And how much is that contributing to those elevated levels of liver stiffness in young populations?
That's a great question. And it kind of leads indirectly to one of the things I've been wondering about, which is as somebody whose BMI is significantly higher than you would guess if you, for example, put calipers on me and look for percentages body fat. One of the conversations at CLDF was about the idea that waist circumference might be a better way to look at some of this than BMI. And I'm wondering if you've got existing data that compares or contrasts the two and gives a sense of the relative value of one versus the other as a measure of metabolic exposure.
So I have looked at waist circumference data. I haven't looked at that recently, but we do expect also there to be a difference between countries. So in a country like China or Japan, you'd have a greater portion of the people that are classified as normal weight with possibly a risky waist circumference versus, a country like Fiji or something. It is going to vary between countries, but waist circumference is probably a good measure. The data are less readily available on a longitudinal basis. So, with obesity, we do have those annual data going back decades. And, the waist circumference data is a little bit less readily available. But comparing the two, waist circumference versus BMI, I think is a useful marker for disease.
Agree. And maybe just to follow up, it's not as standardized. The waist circumference, if you have an untrained personal, you can get a little bit somewhere between the hips and the belly, and then you get variations. I think the big numbers might cut this out again, but I agree, the BMI is just more standardized. But I think from the cardiovascular risk literature, we know very well where that places.
I think that's interesting in terms of modeling and using other parameters other than obesity. Back to what you said earlier, Chris, that obesity rates started to increase again now after the pandemic, and coupling this information with the several papers we have seen recently with the increased amount of alcohol use in several populations, and we've seen this in Europe and in the United States as well. I wonder if going forward we will try to predict the burden of fatty liver disease by combining these two curves, right, of obesity increase and alcohol use increase, because you cannot escape the sad reality that simply the alcohol use has increased. So I would favor that rather than waist circumference, because that's a crude measure of how bad the liver disease will be in the next decade. I don't know if anybody's doing such work, but that will be an interesting concept.
Are you aware of anybody doing such work? Alina, that sounds exactly right. The two have risen. Clearly, the two have risen in most Western countries in lockstep in the last couple of years, and to treat them separately probably is not well advised. going forward?
If you look at it from the regulatory standpoint, the cutoffs are important. But if you look at it from the public health policy, I mean, there's a linear correlation, I would think, that between the use of alcohol and even beyond the NAFLD thresholds, obviously. And I'm worried as a clinician.
Yeah, I've seen, the data from the U.S. show increasing alcohol and our opioid abuse during the pandemic. Those data are just sort of coming out now. We kind of waiting for what the post-pandemic is going to look like in terms of alcohol abuse. I haven't seen the evidence that, it's declined since the pandemic's ended. We'll see what comes out of those data. In terms of the waist circumference, I think Jörn brought up a big point is that, the sampling variability, the measurement error. I guess it's the link between what I've seen is that, the link between visceral fat or abdominal fat and metabolic syndrome versus the way the fat is distributed on the body can have an impact on disease.
So how would you measure that? If we think waist circumference is spotty because of the variability in where people are actually measuring it, what would be a better way to measure that if you chose to do that?
I mean, there are technologies that, look at how the fat is distributed on the body. As far as I know, that a lot of that equipment is fairly expensive. It may not be completely accessible, but there are technologies that can kind of look at body fat percentage and how the body fat is distributed on the body. But it's probably not something that you would find at the general family doctor office.
So I want to try to pull this back to what I used to do as a living, which is forecasting. And in the context of drug development, which is one of the places we started, if I try to pull together what I'm hearing from you, a couple hypotheses come out. One is, and I think Alina made this point, if you're treating later in life and you're treating F2 is not likely to be a cause of mortality, that if the patient who also has F2 fibrosis has a whole bunch of other metabolic factors going on, then you might think about all that as part of the same issue. But even then, one of the things we talk about on this podcast from time to time is the importance of reversing fibrosis versus simply stabilizing progression of fibrosis. So one of the things I would think is that for an older patient that is not cirrhotic, if we were going to treat the liver, we would worry less about reversing fibrosis and more about overall metabolic effect and stabilization of fibrosis. Does that sound right to you in terms of where the data would take you? And B, the rest of you, does that sound right in terms of how the world seems to work or how physiology seems to work? Chris, do you have data? Or is there data that informs that question?
Yeah, it's pretty challenging to look at stabilization versus disease regression given the variability in our diagnostics. But we do feel like lower fibrosis score is associated with lower overall mortality. For an older person, you can make the argument that it's more important to stabilize at that point, and regression may be likely at advanced age. And we would expect overall lower mortality with reduced disease progression.
I guess the information, again, coming back to the concept of fast versus slow, is how rapidly are things changing for those patients. And that's missing in some of those. We don't have that data. We can't provide that data to Chris yet from the diagnostics or the epidemiological data we have. So it's a question, how far is the car driving towards the wall? When will it get there? And this might mean you might want to have a measure of necroinflammation or something that hasn't been linked to anything yet because nobody can agree on what it looks like and this histology and so on. But it might be important if you want to have very precise information.
I think that's correct. And I think one of the difficulties, and going back to the stuff at the beginning, is how often do we measure? If we measure frequently, we've discussed on the podcast a lot, if we measure more frequently, people get more motivated. They see the alterations that they make and they make a difference. If we look at the NAFLD guidelines in the UK, at the moment it's 3 to 5 years to repeat a fibroscan, for example, for capacity. There are now centres who use 10 kilopascals to get people in to be able to just assess for their capacity. So what we're seeing is the rise of kilopascals or other measurements to try and get to the most severe. But that's increasing all of the time. So stabilising is important, but also getting regular measurements so that we know you can do an awful lot of damage to your liver in 4 weeks if you suddenly hit fast food. You can also do an awful lot of improvement, but if we don't have the measurements, we cannot tell who are fast and slow progressors. We can't really tell how the burden of disease changes because we're forever using surrogates. So do they all get a FibFor more regularly? Are there ways that we can alter the pathways to get some of that data? But I think the biggest thing we lose by not being able to monitor is to motivate that patient to speed up the progress, because the more people that get that progress, the more people that keep on that changing. We know that only 10% of people who get 10% body weight loss have kept it off at 1 year. Just making a start there to make it 11%, 12%, 15%, and getting that slow attrition. In the numbers that we're talking about, 1 or 2% difference is a massive change in the outcomes for people's liver health. So we do need to get something that we can monitor more frequently, that's cost effective, that allows us to see what's going on for these people, because everybody's right. Information is key and data is important.
These are really important points. When we look at the model, we know that there's people that don't progress or progress fairly slowly, and we know there's people that progress very quickly. We don't quite have the data to break all that down in the model, so we actually just have an average progression rate. And when we look at lifestyle intervention or a therapeutic compound, the way we would model that is we'd say that maybe this portion of the population will be diagnosed and screened at F3, and that portion of the population that's screened and diagnosed and receives the treatment will have, say, a certain percentage reduction in the disease progression. But that could vary between individuals. So someone who's a slow progressor may have a different reduction than someone who's progressing quickly. So we really need to better identify those who are fast progressing versus slow progressing. The model is holistic, so it looks at national burden using averages. But for clinicians, it's really important to look at the patients as individuals.
Do you have the ability within the model, even at a hypothesized level, to create distributions around that? If a fast progressor is this proportion of the population and goes this quickly, here's the added burden and here's the added value of addressing it. Does those kinds of tools exist?
From a modeling perspective, we can create kind of weighted averages. So we could say that this portion of the population is slow progressing versus fast progressing. When these data come, we're going to find that varies by gender, by age group, by country, by obesity level, and with these other comorbidities are linked to it. So it becomes, fast versus slow progressors probably linked to other factors as well. In terms of modeling, you can definitely come up with, weighted average progression rates depending on the distribution of the population. And we already do that in the model. So we assume that people over 40 are progressing at a faster rate than under 40. We have the data to support that. And we have faster progression among males as compared to females. So it's really getting those more granular data to understand what portion is fast versus slow progressing as a function of age, gender, obesity level, which are going to vary between countries.
So, Alina, you sat up, which led me to think you had a thought.
The thought I had was about this concept of fast progressors or slow progressors. I think we talk about this a lot, but I do wonder in the back of my mind if those fast progressors, we call them because we happen to catch them in a stage of fibrosis towards the end after having been in that stage of fibrosis for several years. And then we caught them moving to a different stage. In my clinical practice, I don't see a lot of fast progressors. So as a big picture, in terms of modeling for drug development or application of approved drugs in the population, I think this is probably low priority because, one, I think it's a biased term. We don't have the population that we follow on a serial basis with any sort of fibrosis estimation to know and identify what characteristics those people have if truly they exist. When the time comes to apply these concepts into a population, the slow progressors are going to be the majority. And that's where I think the most of the thinking should happen. Instead of trying to stratify and tease out, there may be some, but there may be actually just on a trajectory and we catch them late. That's what I was thinking.
Well, I think I agree. Well, obviously, I don't have data to prove otherwise. We've done some analysis looking at the Optum electronic healthcare records and identifying patients with cirrhosis, then looking back for the first coding of liver disease, which is very artificial, of course, too, but you're going to identify two big groups, one that are identified very late, and maybe it's not fast progressors, but late identifiers or something like this. And you're going to have some that have coded liver disease for a long time, and then it takes 7 to 15 years to reach an endpoint. And it's also arbitrary because people are doing a lot of things in between. They might go to see Louise, be scanned, change their whole life, exercise, and then something happens and they regain weight. So it's not a straight path. I agree.
So that's interesting, right? Because that says two things. First of all, if I do the economics of it, the fast progressors matter. If there is such a thing, Alina, the fast progressors matter because on a spend per capita basis and value of spend per capita, you're spending more money in late disease than early disease. You spend more money in fast progression than you do in slow progression. And as a result, from a purely commercial sense, whether you're talking about the pharma companies, the diagnostics companies, or most of the point, health insurers, whoever pays for it, private or public, fast progressors are the place you're likely to get the greatest bang for your buck if you can figure out who they are and whether they exist, number one. Number two, going back to Louise's comment, to figure out whether they exist, you need to track faster than we're tracking right now. And number three, in a disease with a 20% spontaneous regression rate, tracking is going to be confounded by the reality that this disease is not a linear progression, not even a arced progression, but more of a wave progression. So the challenge, I think, would be to figure out what would be a strategy or frequency for diagnostics that would allow you to certify whether, in fact, this was a patient at high medical and economic risk in the short term or not, without testing everybody way more often than you can economically afford to, and the patient's willing to be tested. And the only thing thing that comes up with that is Louise made the point about repeated FIB4s. From what I know, I'm not sure that if that was the goal of FIB4 is the test I would want to repeat. I'm not sure exactly what it is, but I'm pretty sure that's not it, right? Because you want something with decent positive predictive ability.
FIB4 is doomed to increase, right? Because patients get older. That's an absolute truth. So we need better markers, and I would advocate that we need different databases rather than registries and tertiary cares or clinical trials, because those are highly biased towards a more severe spectrum of disease and likely to overestimate outcomes. So if we draw conclusions from those populations or data sets and apply them to the large population, they're going to overestimate, and then goes back to the economic model. We're going to spend a lot of money to test and treat people who don't need to.
Yeah, I mean, we see this in a lot of disease modeling as people consider the cost of the therapy, but there can be significant, substantial costs in screening and then the further diagnostic testing. Any economic analysis really needs to fully capture the costs of the diagnostics and screening program. And at every step, you're also losing patients. So you might screen patients that never come back, even if they are testing, positive. You also have to keep track of how many patients are lost along the way. In terms of modeling, therapeutic compound, if we use heart disease medication, say, cholesterol drug like a statin, we also have to keep track of, compliance persistence with a medication. So we'd expect probably around 50% of patients would stop taking a medication within 3 years, just based on, data from other disease areas. So there's a lot of things that kind of go into cost. And we also have to consider indirect cost. And this has to do with lost work productivity. How many years lived? This is using the World Health Organization disability adjusted life year template, where we look at how many years of lived with disability and how many years of life are lost due to end stage disease, and assigning an economic value to those. Is that you're going to have greater indirect costs when someone develops disease in younger or middle age versus advanced age, as we kind of discussed later, where someone that's first diagnosed with NASH or advanced stages may not progress, and if the indirect economic burden is lower at that advanced stage.
Chris, what's the difference in 3-year persistence of therapy based on things like side effect levels, dose form, dose frequency?
People are, they're told to take a drug, every day by their doctor. There's just going to be a certain natural fall off, regardless of side effects or efficacy. People are just going to stop taking the product. But, if the side effect profile is worse, more adverse events, or potentially less efficacy, they're not seeing any impact in terms of, non-invasive measures. You expect even less compliance and persistence over time.
So if statins are 50% for 3 years, do you have a number, persistence number for a disease, say, with a significant level of symptomatic side effects?
I don't have that number off the top of my head, but I would expect that to be lower. I mean, statins do have, for a portion of patients, do have, significant side effects, but I'd expect it to be even lower than 50%. And that's in the US. So other countries with different healthcare systems may have much better compliance persistence. So it also has to do with the healthcare system itself. In the US, we don't have issues with health insurance, issues with following up with patients that may not exist in other countries.
I think I agree with that. There's regular physician visits that reinforce the concept of this medical treatment. It should be much higher for most patients I'm seeing in clinics. And of course, not having to struggle with insurance aspects. In Europe, it's probably higher.
So we're getting towards the bottom of our hour. I want to know if anybody has any more questions for Chris, and then I've got a 2-part closing question we can spend a little bit of time with.
Well, I guess one question could be, Chris, and we've discussed this a little bit, pharmacotherapeutics, but the other spectrum is the prevention measures, of course, and that goes into the models you said you calculate for patients regressing. But have you done something like spending money on schools, or like New York has done, banning certain cup sizes? Is this is this a preventive measure you could meaningful model in one of your equations there?
Oh, absolutely. Yeah. So we look at how is the future burden going to change if we prevent childhood overweight and obesity. The challenge with that in terms of policy making is that the impact is going to be potentially decades later. And, policymakers, they're concerned about the next quarter or the next year budget. They're not necessarily thinking 20, 30 years in the future. What is the burden of liver disease going to be based on what's happening among young adults today? So it's kind of a short-sightedness. We're not considering, the policymakers are not thinking about that enough. The best intervention would just be to prevent disease to begin with. But again, it's the time frame that makes it challenging.
Chris just said it there. It's all about prevention. The data there gives us the evidence to be able to put in prevention, which is a lot cheaper, but we don't use that evidence. And that's the one thing I'd love to see reversed. Let's model, let's put in the care packages, let's put in the right strategies. It's expensive to start with, but it reaps its rewards on any modelling that I'm aware of as you go down that timeline. And that starts early with schools. We've got a sugar tax in this country, obviously, for children under the age of 16, I think it is, can't buy, or they pay extra additional on drinks. to try and change that, which seems to be working. So it's all about keeping your liver healthy. But you've got to know your liver's condition. But we don't do that as part of anybody's health screening at any stage, apart from a liver function test, which isn't the most accurate thing in an organ that regenerates.
Well, my swear jar is anybody who uses the phrase liver function test to describe AST ALT owes me $20 for exactly that reason. I feel a lot wealthier, Louise. Now I know that you're going to be in Barcelona. I know who's paying for my first drink or my breakfast or something because you owe me out of the swear jar. Okay, you actually teed up my closing question, which is part of it. One is, what is the best place we can use the data that we have better? And the second is, what data that feels to you like it's within the realm of what Chris or someone who does what Chris does can produce, do you think would help most around the either drug or diagnostic development issues?
I'm going to jump in on that because thinking about what you're saying there, I think the importance of the data that Chris and other modelers do is it allows us to potentially develop comorbidity pathways. And it's something that's not currently being developed. We're all siloed and we talk about metabolic disease. We've talked about it on this episode, but we still don't have endocrinology assessing liver disease. We still don't have obesity medicine assessing for liver disease. We still don't have any bariatric medicine assessing for liver disease. So we're still very, very separate, but using the strength of that data to try again to say we can all cut costs and use that money to finance and fund some of the investigations that we want to help people and their families live longer, better, healthier lives. The data's there. We just need to restructure our thinking to use it better.
Restructure thinking and restructure data sets. And I think it'll be the day that I'm able to hand off something to Chris and say, here's a population-based study screening for liver disease using an advanced technology. And there are some ultrasound-based or transit elastography-based ones on the way in Europe. So this is great. On the other hand of the spectrum, advanced EU and US consortia, Nimble Litmus, generating lots of data. And it'd be very exciting to see how you would tackle that data to build them into your algorithm and really give you better grounds to then model future risks. And I think that's urgently needed.
Very well said. I agree. Compared to maybe a decade ago where we anchored everything on what the biopsy told us, nowadays we're so much better positioned by having multiple layers of testing and assessment of liver disease, which is a big improvement. I think where we need to go forward is collecting data, not specifically related to the liver events, but the comorbidity related outcomes that we talked before, because everything is a competing risk. If you don't have the competing risks, you can do accurate modeling for liver events. We basically need to continue to collect data. We need to create these large databases that have longitudinal follow-up that's significant. I wouldn't base modeling on or outcomes on 1 to 2 years of follow-up. There's several papers on that, and we should strive to wait a bit more patiently to collect data that can actually be put into a big pile to be churned and modeled for some meaningful results.
Yeah, these are some really good points. Is that's going to be the path forward to developing the most accurate models, is having these non-invasive measures in normal general populations that look at longitudinally long-term what is the true rate of disease progression and how that varies between individuals based on risk factors. And then also in terms of cost effectiveness, and especially cost effectiveness, is this issue of comorbidities. What is going to be the change in these other comorbidities for any type of NAFLD or NASH intervention, and understanding the burden of comorbidity and how they might be reduced as a result of an intervention would be, very compelling in terms of showing cost effectiveness.
Yeah, all great points. And as I'm listening, one of the things I'm struck by is the difference between where I come from and where we are now, which is that marketing stats are future-oriented and highly probabilistic, because fundamentally what you're trying to figure out is the probability that investment will pay off, whereas this needs to be a lot better nailed down and a lot more solid. And going back to the point that I think Alina might have made first, or you, Chris, the idea that we're doing 1 or 2 year and treating that like it's a time continuum for this disease virtually means that not only are the medical stats going to be confounded, but the marketing stats are going to be confounded because nobody can do decent future prediction. So I think one of the good things that will either come out of the consortia or thinking about it differently is we will get smarter about how to use prior probabilities and those things to decide where we can and where we can't make sensible bets about investment. Because if we've got to wait for a whole bunch of 10-year data to roll in that we're only starting to collect now. Louise asked this question last week in a very different context. Like, what can we, if she asked Naeem, well, if we've got to start long-term studies for adolescents to know what to do with them, we're giving up on a whole generation of adolescents. Her point was, therefore, we have to do better. I think this is another one of those, which is that accepting limitations of the data we've got to start to think about commercially how to make better investment decisions, because so far the history has not been good. It's why so much of Big Pharma has backed out. We just have to figure out how to do that better. And I take the point that goes, we don't have the data, you would ideally have to do that.
Can I just ask, just while you're all talking there, do we have an opportunity in the context that a lot of nations are targeting pre-diabetes to put them on pathways? We've just, in January, got a pre-diabetic pathway, and it puts them into monitoring. But to the best of my knowledge, not one of these pathways are monitoring FibroScan, for example, or doing non-invasives. But we must be able to link into that data to look at, we know that you can reverse diabetes and present it into remission, but it's liver fat and pancreatic fat you have to reduce. So improving the liver condition, is that a way to prove cost effectiveness in this population? If we can stop people becoming diabetic by watching and using liver parameters as the biggest change, is that a way to set, because diabetes is massively expensive. So that's a program that's certainly going on in this country, and I'm sure it's going on in most of the West developed and Western world, to target prevention of diabetes. So do we need to link into those databases? Do we need to get some of that information and look at the liver, the ELFs, the FIB4s, any of the markers, the NIS4, any of the ones that we can do to see whether or not we can generate that data?
I think it'll be very compelling in terms of cost effectiveness to show a reduction in new diabetes cases. Now, we haven't modeled that specifically. We've looked at, the sequelae of diabetes can be pretty complicated in terms of disease course and costs. But we do know that with increasing fatty liver disease severity, increasing inflammation is associated with greater incidence of these sequelae of diabetes. That would greatly help in showing cost effectiveness for any intervention.
You know what? Unless anybody has anything else to add, I think that's a great note on which to end this portion of this episode. So let me thank Louise and Jörn and Alina and Chris in the order that you go around my screen counterclockwise for joining today. And I will step out, and this recording will be back in a couple of minutes with our other discussion, the one about MRE. And you will actually see Jörn again in 2 weeks, Louise next week, and Alina. We got to work that out, but sometime in the near future. And Chris, thank you so much. Thank you, everybody. Enjoy the rest of your day, and I'll talk to you all soon.
Thank you.
Thank you.
Thank you all.
Bye. Thank
Bye-bye
you.
now.
And now, today's extrasode on clinical uses of MRE in medical practice, sponsored by Resoundant.
This next section is a little different for Surfing the NASH Tsunami. Usually, when we have an extrasode, it is related to the main episode and includes mostly the same panelists. This week's extrasode was recorded on January 27th. The only common panelists are Louise and me, and on this conversation, we are joined by Stephen Harrison, Mazen Noureddin, Scott Reeder of the University of Wisconsin, and Kay Pepin of Resoundant and the Mayo Clinic. Our topic is the use of MRE, and it turns out, to a lesser degree, MRI-PDFF, in diagnosis, treatment, and monitoring of patients in practice today outside the context of drug development, and our episode is sponsored by Resoundant. We pick up here with me welcoming the extrasode panel. We have a fantastic panel of people with us, in addition to Stephen and Louise, who just tend to show up for this and everything else. Good morning, Louise, or good afternoon, Louise.
Good afternoon. It's definitely afternoon here and nice and sunny.
Yeah, but that's morning here and not bad either. Good morning, Stephen.
I'm good.
We have Mazen Noureddin with us, who is in Los Angeles, where it's really early. Good morning.
Good morning.
And then folks who aren't with us quite as often, we have Scott Reeder from the University of Wisconsin. Scott, how are you today? And thanks for joining us.
Doing fine, thanks. Yeah, keeping warm here in Wisconsin.
And then from one state over, we have Kay Pepin, who is in Minnesota with Resoundant and Mayo. And Kay, how are you this morning?
Good, thanks, Roger.
So with all that said, why don't we just dive in? What we're going to do today is, as I said, talk a little bit about MRE and its use in practice. But before we do that, if you listen to this podcast, you know Louise, you know Stephen, you know Mazen, you don't know our other two guests. So Scott first, then Kay, please take a minute or two. Just tell us a little bit about yourselves, what you do, your work.
Sure. Well, I'm a radiologist and I'm also an engineer. So I think a lot about clinical imaging. I think a lot about the nuts nuts and bolts and technology behind imaging as well. I'm vice chair of research in our department, and I'm also our clinical chief of MRI as well. So those are some of the things that I do. And fun thing, well, I'm from Canada originally, so maybe you'll hear my accent come out.
Kay, go ahead.
Yeah, I'm Director of Research Translation at Resoundent, and I also hold a joint appointment at Mayo Clinic in the Advanced MRI Laboratory. So my career so far really has focused on imaging biomarkers. It's a topic I'm very passionate about. Today, I really focus my efforts on supporting the use of MRE in clinical trials, whether it's the day-to-day applications or through our work with the FDA Biomarker Qualification Program. And then also with QIBA, the Quantitative Imaging Biomarker Alliance. This is a really fantastic organization whose mission is to improve the value and practicality of quantitative imaging biomarkers by reducing variability across devices, sites, patients, and time. So for the random fact about Kay, growing up, I spent several summers picking and selling 1.5 acres of sweet corn. So quite a different job from what I'm doing today.
Did you ever have to detassel the corn?
Oh, yeah. I learned that a field of corn in August is at least 10 degrees warmer than anywhere else. People get very passionate about that too. Not quite the same as imaging biomarkers, but...
No doubt. That and the smell of pigs in Iowa in the summer. But
sounds about right.
My first job was actually baking bagels. Trust me, a bagel oven can get really hot in the summer when baking bagels, although it isn't...
Is it as hot as the non-invasive testing market for NASH?
Yeah, certainly not as hot as it's about to be. Non-invasive testing is going to get crazier and crazier. So with that, why don't we launch into today's topic? I've asked Mazen and then Scott and then Kay to take 3 different perspectives on the question of MRE's role, not in drug development, which we talked about, but day-to-day patient management, efficient testing, and then tests that work and are efficient and are easy to read. And Mazen will talk about some of his work on that. And then Scott from a radiology point of view, and Kay from a more resounding point of view, and a kind of what are the practicalities and logistics of making that happen in 2022. And then we'll do quick Q&A, and then we'll be done. So Mazen, the floor is yours.
I would like to talk about my clinical experience with MRE. I finished fellowship in 2013. I was a fellow with a young faculty by name Rohit Lumba. So we worked together on MRI-PDFF. He started doing MRE research. And then I moved to Los Angeles, and I was a big believer of this technology and what it can provide to the field and the patients, importantly. And I mentioned to Scott earlier that he wrote a paper about the Medicare cost of it and how it can be done as just a limited abdomen test without a contrast and be cost effective. And it's not that expensive if it's tailored well. So I started doing MRE as part of my clinical practice. It has been years now, and the insurance covered it. And I have had a large cohort of MRE patients. I'll do it myself. I went and checked myself with PDFF and MRE if I have fatty liver or not. I used it as sequential testing as well after transient elastography. And sometimes I used it as a first tool when I felt the patient will benefit from it immediately rather than just going through other NITs, such as BMI of 40 or so. That will lead to my topic, which is the MAS score that we just published in hepatology. You all are aware of the FAST score, which came out in Lancet Gastrohepatology, and Stephen is part of that work. And basically it is because we found that the F2 patients, they have increased morbidity and mortality. I thought that Stephen and Phil Newsom and other colleagues, they had a great idea to look at that target group in particular for NASH and F2, to look for it non-invasively to qualify for clinical trials, and eventually it will be in clinical practice because those are the people that we're going to treat when we have drug approved. So it was a great paper, but when it came out after they presented in the ASLD, I said to myself, well, we have data from UCSD that MRE and PDFF are more accurate than a FibroScan. Why we don't do it a similar way? We don't do similar score based on MRI-PDFF and MRE. We started with validation cohort. Although we have a lot of MREs, not everyone had a biopsy. So the derivative cohort was about 103 patients, and they had paired liver biopsy, PDFF, MRE, and labs within 6 months to make sure there's no change in the patient characteristics. And through logistic regression, we looked at the PDFF and MRE were the backbone of that test, but we looked also at other variables that can improve the test. And we wanted to make it simple, and we used the best variable that came out, which was AST, followed by ALT, and that one. And we ended up putting the score, and to our pleasant surprise, the area under the curve from that study, or that first cohort, cohort, derivative cohort, came out as 0.6, which was higher than the FAST previous publication. It did also have the MAS score again to detect NASH and F2, other than the gray area under the curve. Very good MPV sensitivity, reasonable specificity, and reasonable PPV for the population we studied. I then reached out to Stephen and I asked him to share with me his cohort, which is the well-known cohort that he has been working on for years. And he's recently published the JHAP prevalence paper. So we used that cohort with the parameters I mentioned, PDFF, MRE, biopsy, and AST within a short time frame, and we validated that MAS score. Stephen was essential to that paper. We had a great input from him and great ideas, and his cohort actually came with a higher area under the curve, 0.93, again with excellent MPV sensitivity, very good specificity and PPV. And then what we did similar to what FAST score and NIS score did, which is rule out and rule an area just to increase your confidence to enter patients' clinical trials. And people can use them on their pleasure, like high sensitivity or high specificity, or even in between. And I don't want to go into their numbers, but what we found that the indeterminate zone was quite narrow, less than 20% for the derivative and validation cohort. So it's out there. It's great to look for patients in NASH and F2. And the last thing I want to say is that we did road testing for longitudinal correlation or longitudinal use of that score. And we used that in the resmetirom open label cohort on a small cohort. And what that PDFF and MRE AST-based score did, that they showed that nicely that in the resmetirom group, the score drops nicely. And we know that drug is effective from previous trial. So it has shown that it can be used longitudinally to predict pharmaceutical or drugs response during clinical trials. The last thing I will mention, I will stop here, that this score is MRE heavy, if I want to say. It's MRE plays significant role in it. So some people say, well, it's probably the AST, which we think probably the FAST score is dependent a lot on AST and can change it. No, that score is actually MRE is probably the main driver, followed by PDFF and then AST the least. So with that, I'll stop and let other people talk.
So Mazen, first of all, thanks. That was fantastic. Before we go on to Scott, Stephen, as a participant in some of that, do you have a comment you want to share before we go on to Scott, next part of the presentation?
Yeah, I mean, I think the work Mazen has done on this has been really groundbreaking, and the utilization of the combined PDFF, MRE, and AST to identify the at-risk NASH patient. And just to take it a step further in the work that he's done with resmetirom, it's really validated the fact that in using this score, we can do a very good job of identifying the F2 at-risk NASH patient, so the F2 or greater NASH patient, and good at ruling out those that don't have the disease relative to FAST score, for instance. So more work to do in that regard, but it certainly speaks to the power of the technology and its utilization in the field right now.
Scott, your floor.
Well, I've known about MRE for a long time. In fact, I first became acquainted with it back in the 1990s when the seminal paper from the Mayo Clinic came out. It really, in my mind, gained traction around 2007 with that seminal paper that came out also from Mayo Clinic looking at the relationship between fibrosis. I've been fortunate to know Dick Eman for a long time, and that was around the time that my lab was developing PDFF, around 2005, 2006. Right around when 2007 and MRE came out, I was lucky to be able to collaborate with Dr. Eman, and we were able to obtain a prototype instrument. So we've been doing MRE for about 15 years now at the University of Wisconsin. So we've had a chance to learn a lot about the ups and downs of it. Just briefly, for those of you who are not familiar with MRE, it's very similar to MRI. The main difference is that it does require a driver device that is essentially a plastic paddle that is placed in the right upper quadrant, and it's just secured with a neoprene wrap, and then it's connected by a tube that goes outside of the magnet that is essentially connected to a subwoofer that puts in vibrations at about 60 hertz. So it sort of jiggles your right upper quadrant. I've had that done myself several times. It's really not that uncomfortable, and the machine just gives sort of a gentle vibration to the rib cage, which transmits shear waves into the liver. What it does is it synchronizes that with the scanner and uses motion sensitizing imaging methods that create wave images that you can watch propagate through the liver. And then the scanner essentially is able to figure out how stiff the tissue is from that. The original techniques were about 4 breath holds. You can do it in about 1 breath hold right now. So it's actually quite fast. The whole thing can be done in less than 5 minutes. And then typically we also want to add proton density fat fraction, PDFF, to this as well, which is also a 20-second breath hold. So you can be in and out of the magnet with both an MRE elastogram and PDFF, which we almost always do together in less than about 10 minutes of table time. And so we usually schedule these in about a 15-minute slot. Our original uses for this actually interestingly came from children. Our pediatric hepatologists are reticent to biopsy children with suspected NASH. When the children underwent anesthesia for their biopsy, we would actually bring them to the MRI suite first, do PDFF and MRE elastography, take them to the interventional suite to do the liver biopsy, which was great because we learned a lot that way because we could correlate the biopsy findings with MRE elastography. And no surprise, we found really terrific concordance as well. Other applications that we found quite quickly were actually with Harvoni therapy for hepatitis C, which, as you know, at least early on, was a very expensive treatment, and patients weren't eligible for insurance coverage unless they had F2 fibrosis at least. So I actually got to know our pharmacists quite well, and they wanted to have the most accurate but non-invasive method for detecting fibrosis. And so I learned a lot about Harvoni therapy and hepatitis C, and we used that as determining whether the patients would be eligible. And then there's a number of other applications as well, but really where we're gaining traction is in suspected NASH and really determining whether or not the hepatologists want to send the patients to biopsy or not. One of the questions that comes up a lot is the cost issue. There's a lot of confusion about the issue of cost, and there's a lot of different ways of looking at it. One way to look at it is what the insurance pays, and I think a good metric of that is looking at Medicare costs. We have a few different protocols. One, we have what we call a rapid fat iron protocol, which we use the methods that we use for PDFF. Also, we can quantify liver iron too, and we can talk about that later. So in 1 breath hold, we can get liver fat and liver iron concentration, LIC. What we've been charging for that is an MRI abdomen without contrast with a limited 52 modifier, which is basically about half the price of a regular non-contrast MRI. And it turns out the cost for that is about the same as an ultrasound. So PDFF and LIC are about the same cost as an ultrasound. And then about 3 or 4 years ago, there was actually a new CPT code for elastography as well. That cost is a little bit more, but not a lot. Medicare cost is under $300, a total technical and professional fee to do an elastography. And so we have dedicated protocols where we do elastography and we also do PDFF at the same time, and we charge for a PDFF. So that's just a little bit more expensive than an ultrasound, but that gives you an idea. The only other piece of this that is a slight complication, PDFF can be used as the regular scanner with just software in order to acquire the images and reconstruct the images. Elastography does require the additional driver equipment, which does add to the capital cost somewhat, and it means that you have to have this on any scanner that you want to do it on. But we actually have this on all of our scanners at Wisconsin, and so from our point of view, access is exactly the same. That may not be true at your local institution, so you want to know how many scanners and which scanners have elastography. And then the last point I'll make is that elastography and PDFF work great at both 1.5 Tesla and 3T, and those are the 2 main field strengths that are ubiquitous within most modern clinical practices.
We do it the same way that Scott's Place do it. I made up a name, we call it MREFF to abbreviate it, which means MR elastography and fat fraction at the same time. So we get both of them done on a lot of patients.
Okay, but I was hoping you'll talk a little bit about some of the practicalities of availability and access and other things that people should understand about utilization.
As we've heard already this morning, MRE is a fantastic non-invasive tool, and MRE-FF is already used widely in clinical practice. The goal has always been to replace liver biopsy for fibrosis assessment and really improve clinical care for these patients. We've been really thrilled with the adoption so far. MRE is actually quite widely available. There's approximately 2,000 MRI scanners globally that have MRE available, 1,000 of those in the U.S. We estimate that in about 95% of NAFLD patients living in the U.S. are within a 1-hour drive of MRE. So if MRE is not available at your institution, ask for it. Like Scott said, most radiology practices want to be responsive to clinician requests. And for new or existing MRI scanners, adding the MRE application isn't challenging and should cost less than purchasing other non-invasive devices such as FibroScan. And for the actual exam, we've already talked about this, but if the clinician orders just an MRE and PDFF or MRE MRI-PDFF. This is a low-cost rapid exam, and based on the 2019 CMS data here in the US, the cost can be around $170. So MRE can be cost-effective. In the 2020 paper by Villar-Gomez in Clinical Gastroenterology and Hepatology, FIB4 plus MRE was the most accurate non-invasive test for the detection of cirrhosis and was only marginally more expensive than FIB4 plus VCTE. That kind of gets into the adding MRE to the scanner and both ordering it for patients. But on the research side, I think I want to highlight a few things that it's been a really great year for MRE. It's exciting to hear about Mazen's work on MAST, as well as MeFib from UCSD, and both combining Mazen and Alina Allen's work demonstrating liver stiffness can predict clinical outcomes, both in cirrhotic and non-cirrhotic NASH. These are really important papers that will help accumulate the evidence needed for regulators to accept these imaging tests as trial endpoints. We hear they're already used in clinical practice. It's time for clinical trials to catch up. We hopefully replace biopsy eventually with these NITs using MRE and PDFF together. We're there. We're very close.
Kay, thanks. That's great. Stephen, I'm looking at you. I'm flashing back to NASH-TAG and Kay's comment about we're very close. And I would love for you to comment a little bit about how close and where you feel we are close and where you feel we got to get to.
Yeah, I mean, I think with anything, the FDA is driven by data. We are accumulating a large body of data with MR elastography, particularly as it pertains to the diagnosis of the at-risk NASH patient, those people that are likely to need pharmacotherapy to help them. And in parallel, we have drug development rapidly moving forward such that we potentially will have our first FDA-approved drug, if not this year, then next year. So in parallel with drug development, we have non-invasive testing development, and I think MRE has really taken a huge step forward here, particularly with that context of use of diagnosing the at-risk NASH patient. The other context of use that I really like about MR elastography is its ability to predict long-term outcomes. This is exactly what the FDA wants to see. What we need to do is take a closer look at all of the data that's been done to date with MRE and outcomes and really summarize that in a very succinct way for the agency and for the field so that we can generate the groundswell of not only academic enthusiasm for this, but also patient-level enthusiasm and provider-level enthusiasm and, quite frankly, lawmaker enthusiasm to drive the FDA to hopefully change to a non-invasive test. What we got out of NASH-TAG was a willingness of the FDA to listen and look at the data and see where we are relative to changing to an NIT. And I'm hopeful that that'll happen. The one area where I would like to ask Kay, maybe Scott, a little about is really the other context of use. So I think of non-invasive tests with three contexts of use: the diagnosis of the patient with at-risk NASH, the long-term outcomes, and then second, as Mazen alluded to, predicting response to therapeutic intervention. And what I know about MR elastography is that we're really good at identifying when MRE is worsening, that's linking to worsening of underlying liver disease. And we talk about 15%, maybe 20% worsening of MR elastography. And I think that gets us over the coefficient of variance of MR elastography and predicting that outcome.
One of the cool and profound things about imaging is that it's really the only way to evaluate an entire organ short of doing an autopsy. The fact that you can look at the whole disease process over the entire organ is really amazing, and you can do that with both PDFF and MRE. This is probably one of the fundamental reasons why the coefficient of variability is so much better with imaging than it is with biopsy, because you're getting the whole organ as opposed to 1/50,000th of the sample. It's really unfair in many ways to the pathologist. Another area that's going to be very exciting and is going to help workflow and accuracy and standardization is artificial intelligence as well. So we have standardized or automated reporting. And Mazen, that gets to your last point, is that especially with these volumetric imaging methods like MRE, you can segment the whole liver very easily. And now we're almost there, but I predict within 6 to 12 months, we're going to have automated volume measurements of the liver. And then you could ask those questions and see whether we need to normalize or correct for volume, or just simply look at liver volume, like accurate liver volume as a biomarker in itself, which would be a really easy one and interesting one to look at. I don't know what Kate thinks.
Hey, Scott, let me just foot stomp what you said about the amount of liver tissue we look at with a biopsy. You mentioned 1/50,000th, which it's actually a lot less than that.
Okay.
You're taking a core piece of tissue out, but you're only looking at about 1/14th of that core piece of liver. So it's really about 1/700,000th of the liver rather than 1/50,000th, just for perspective.
Stephen, as you were talking about 700,000th of the liver, I was thinking about needle in a haystack, and that brought me back to the last time we talked on this podcast about looking for needle in a haystack, which is balloon hepatocytes. If in fact it takes you 80,000 cells to find one balloon hepatocyte that 9 pathologists can agree on, which is Quentin's work, and you're only looking at 1/700,000th of the liver here, then it seems to me that the odds of finding a balloon hepatocyte in a biopsy, I can't quite get the math on this, but it's infinitesimal is the phrase that comes to mind, and that might be an overstatement.
This is exactly why we need to move beyond the biopsy and why the whole conversation we've had here is about the holistic view that this image analysis gives us relative to the disease state. And at the end of the day, any injury to the liver results in a scab in the liver. It results in fibrosis in the liver. If we have a tool that's very good at measuring this scar in the liver, then at the end of the day, do we really need to measure the amount of ballooned hepatocytes in the liver? We have been so in the weeds on this thing. It's time to step back to 30,000 feet, realize what we're looking at, and it's all about outcomes. We've already shown that MRE can predict outcomes. At the end of the day, that's what we should focus on. That's really where the utilization of this tool is going to be brought to bear, in my opinion. And I'll just add, incidentally, Scott, you made a comment very early on about having your own MRE done and that it jiggles the liver. So just parenthetically, in our NASH patients, when we originally send them to MRE, they actually can have some discomfort because the capsule, Glissen's capsule, is stretched. And so if you are set up for intermittent right upper quadrant pain, when you jiggle the liver like that, it actually, we've had patients come back and say, yeah, that hurt. But here's where it gets really cool, because with our drug therapy, where we're removing liver fat and we're shrinking Glissen's capsule, when they go back a second time and they say their liver doesn't hurt anymore, like there's a direct correlation between reduction in liver fat.
Sounds like a sonographic Murphy sign when we push with the ultrasound probe on a gallbladder.
Well, looking at Scott, I don't think he had any pain when that thing was vibrating.
Okay.
Well, I appreciate that.
Okay. So
I just have one more question.
Go ahead, Louise.
Because I think it was Scott that commented on reading iron within the liver, particularly for FibroScan and things like that. We use it. It said that iron can interfere with the score and the potential stiffness, and therefore you can't read it particularly well. Have you ever seen any correlation between high stiffness and high iron, or with the MRE? Is that able to pick that out so that it could help us in our hemochromatosis patients?
Sure. Well, I'm going to tell you just a very quick, funny story. The very first clinical MRE that I ever did failed miserably. And it was in a patient with, in retrospect, with a serum ferritin of about 10,000 and had iron off the charts. And so in severe, extreme iron overload, MRE can fail. The technical success rate of MRE is well over 95%. So it's very uncommon that it fails. But in these cases, it will. So I called my hepatology colleague and said, well, I have good news and bad news. The bad news is that the MRE failed, but the good news is that I gave you a diagnosis that you didn't know. The ferritin was in retrospect. He had severe iron overload and he had unsuspected hemochromatosis. But sure, if it is technically successful and there's fibrosis related to whatever disease process, you'll pick up the stiffness quite well. But with PDFF, actually, this is one thing that people don't talk about, is that you also get liver iron concentration for free, all in the same breath hold as well. So really with the hepatogram that we've been talking about, or the MRE-FF, we should really call it MRE-FF-LIC, you get stiffness, you get PDFF, and you get liver iron concentration as well.
Scott, I love this story. I think a pathologist heard what's your research up to and chose the patient and sent it to you to do your first MRE.
All right. Closing comments from everybody. Okay. If you're practicing right now, how should you be thinking today, all things considered, FDA, reimbursement, location of machines, state of knowledge? How should you be thinking today about integrating MRE or MRE-FF?
I'll preface this with, I'm not that kind of doctor, but I will say that if I were practicing, I would send my patients that I was suspicious for non-alcoholic fatty liver disease to get an MRE and PDFF. Stop asking them to have a biopsy. If we're not suspecting other etiologies of liver disease, we don't need a biopsy for that anymore. Then based based on Alina Allen's work, we could have some idea of who's at risk for progression to liver-related events. And I'd call them back if they have high liver stiffness for more monitoring. But otherwise, if they have a low liver stiffness value at baseline, let them go and have them come back in years later. Looking forward, it'd be great if we have a drug approved to treat non-alcoholic fatty liver disease. And instead of screening with biopsy, we could screen with these non-invasive tests, whether that's MRI-PDFF and some other additional blood tests or what that looks like. But then we could have both identify who could benefit from this treatment and also monitor their response.
That's great, Kay. Thank you so much for that. Stephen, why don't you go next?
I couldn't agree more with Kay. I love the utilization of both PDFF and MR elastography in my clinical practice. I don't always use it as a first line. I get FibroScans in clinical labs in all of my patients. And remember that with 100 million Americans with fatty liver, about 75 to 80 will grow old with their fatty liver. So we're really targeting the at-risk patients. And this is where I think the world of non-alcoholic fatty liver is beginning to shift and pivot, where we begin to use sequential testing of our NITs to really refine where we need to be with these patients. So for me, if I have a flag, if I have an indeterminate value or a positive value on my initial testing, those are the people I send forward for MR. It would probably be quicker than that if I had less than an hour round trip for all of my patients. So as we begin to understand how to implement this technology and really get at how good it is, I think all the work you're doing, Kay, in driving the ability of local radiologists to have access and clinicians to have access to this tool will be very, very important.
MRE is in my practice and PDFF as well. I use it the same way that Stephen uses it. We're not going to jump on it as the first test. I think sequential testing became almost the standard, especially in those that know how to do NASH. My biggest thing is, and I want to thank Journal of Hepatology and their editors, this is now what's happening in clinical practices. I still get these sometimes reviewer here and there that say, well, you did a FibroScan or MRE first before the biopsy, so your cohort is biased. And I want to argue with them, and I say it's actually unethical now to have just the NASH patients walking into your office and just jump into biopsy. MRI-PDFF, MRE are here to stay. We need further steps to replace liver biopsy in phase 3 trials. We don't have to do liver biopsy in such a large number of patients and have a screen failure with a tremendous number of patients. Many of them, they have disease, but they missed the balloon cell and they did not get enrolled.
I agree with all of these comments, and I would just add a couple of things. First of all, I think the one myth that we all need to get past is this whole myth of MRE being so expensive, and we've talked about that already. The cost is really on the order of the other non-invasive tests that are being performed. That being said, it still is a precious resource. There are about 2,000 MRE units out there that we know of, but I would add that there are about 25,000 MRI scanners in the United States, and so there's a long way to go in terms of disseminating this technology. There's probably more versions of the PDFF software out there as well, and in fact, it's actually one of the most commonly adopted software on all of the major vendors, and so PDFF is already widely available, and MRE is slightly behind. It is a precious resource. We do have to be mindful of it, so what I'd really like to see are more standardized guidelines, whether it's FibroScan first, or ultrasound elastography, or MRE elastography, and when to go from one test to another, and how exactly that's done. There's a lot of work that needs to be done so that we can use these technologies appropriately.
So, Scott, one of the things I'm inferring is that there's an interplay between how fast the MRE technology diffuses from the 2 to 25 or wherever it winds up, and the need to really be careful about protocols, because protocols have scientific value. They also have practical, logistical value. If I were a practitioner, one of the things I would be keeping an eye on is how much technology was available, how close to where I am.
Absolutely. So that matters as well. And guidelines could be if you live in Rochester or Madison, where we have lots of access to MRE elastography, that might be different for a local patient as opposed to one who needs to drive 4 hours from northern Wisconsin or northern Minnesota. So that's very true. But I think the key thing is I'm very enthusiastic about these biomarkers. I think there's a lot of value for all the reasons that we've been talking about, but using it in a thoughtful manner is really what I'm trying to say.
You've got imaging. Have you ever tried doing it with brief intervention with the patients and seeing what the response is? Because patients respond very well to FibroScan because they can see it. And where they can see a difference, they become competitive. And whether or not you've ever looked at the benefit of that in detailing the scan to see whether or not it motivates and it induces behavioural change better.
It's a research study I've certainly always wanted to do, but it's one of those things that's too many projects, not enough time. But I don't know if you've seen the MRE images, but if you have a red liver, it hits you. This is something, red is bad. I've always heard you say if they can see the movement in the FibroScan values, they feel like their weight loss meant something, showing them your liver went from, well, probably not red to green, but from green to purple. That would be impactful. I agree with you completely. It's something we should look at.
We'll get across the finish line when, those conversations you had at a party of, hey, what's your cholesterol? What's your HDL, your LDL, right? How many times have you had that conversation with your friends? And now it's calcium score for coronary arteries. I think we will have made it when people know their PDFF and their liver stiffness and talk about that at the cocktail parties.
Well, I thought you were going to go all the way to what color is the liver on an MRE. I'm purple, I'm green, I'm red.
Well, it's funny Scott says that, because I do this and I do wellness. And when I do groups of guys, they all come out of the room and they compare. Of course, I can't discuss their individual results, but they're chirping around the dinner table. They're talking about, and then when they come in for their next ones, I beat you, I did this. It really does. And guys respond really, really well to data, making it destigmatizes it. Because their comment is, well, why wouldn't I want to know I've got fat in it because I can do something about it? So you're perfectly right. It's an amazing topic conversation, because then they all compare their cholesterol level, their statins, their antihypertensives, and their diabetic meds.
And now for the Season 3, Episode 16 Business Report.
Our opening of the week to all our Ukrainian friends and colleagues, Svuda Ukraina, all will be Ukraine. And I continue. Remember when I mentioned that for whatever reason, February is always a little light on downloads? Here's more proof. Of the 4 weeks whose Wednesday was in February, only one of those topped even 825 downloads, although that one was over 1,200. But in the first 3 weeks whose Wednesday has been in March, all three have been over 1,000 downloads, and one went over 1,500 to become our third biggest week ever. I'm not a bad data analyst, but I don't get it. That said, I'm hardly complaining. Just keep listening and downloading. We'll all do fine.
Let Roger remind you about the next 3 weeks one more time.
Next week, Scott Friedman, Neil Henderson from the University of Edinburgh, and Stephen will be here. We may stick with the original topic even without Jonathan Epstein, but we're equally likely to come up with something novel and equally fascinating. Remember, the last time we talked about Scott's work in the context of innovation, we wound up with Conversation 46.2 as a summary, and that's had 1,400 listens. So this should be good. Watch for our LinkedIn and Twitter posts and then Facebook during the week to see what we're going to talk about. The 2 weeks after that, we'll preview the Innovations in NAFLD Care 2022 workshop with co-chairs Jeff Lazarus and Jörn Schattenberg and a couple of other participants. And then Jörn Schattenberg and Naeem Al-Khoury will join us along with Mazen and probably Stephen to share thoughts about what the NAIL NIT retrospective analysis might be able to tell us. Later in that month, we'll preview at least one of May's conferences, and we will discuss an interesting recent article.
This week's news from the Vault.
It's interesting. We've had a lot of Vault downloading in the past 3 weeks, but the pattern from week to week varies. This past week, Season 2, Episode 25, the discussion of the San Antonio Military Medical Center study, sizing the potential NAFLD and NASH populations prospectively, received a lot of attention, as did Season 3, Conversation 12.4, a 13-minute cut from last month's episode on NASH and non-Hispanic Black Americans, specifically asking what will improve NASH care for non-Hispanic Black Americans most and fastest. Also, the old standby Season 2, Episode 46.2, the one I just mentioned about advances in Paris NASH, had some interest for the first time in a month. Truth be told, though, just about everything back there is worth listening to again if you need to go back to that topic for whatever reason. And with that, I'm off. I want to thank our team, Magic Mike, Eric, Steve, and Murph the Magnificent, for a fabulous week handling one more new challenge, this time new episode and old extrasode. I hope what we put together works for you. We'll be doing this again soon, so please let us know what works and what doesn't. I'm done. Stay safe, surf on. I look forward to seeing you again next week on the podcast. Bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.